Without further ado, please join me in welcoming Dr. Run Yu. He is the co-director of the Carcinoid and Neuroendocrine Tumor Program here at Cedars-Sinai Medical Center and an endocrinologist. Many of you may already know that if you're a patient here, you can book an appointment with him. Many of us do have endocrinology issues along with our neuroendocrine. So please welcome Dr. Run Yu.
So good afternoon. Thank you, Joanna, for the nice introduction. So in the afternoon, in the next session, we're going to talk about some advances in neuroendocrine tumor therapy. Our first speaker is Dr. Farin Amersi. She's a surgical oncologist. She's one of the expert surgeons of our center, and she's going to talk about the treatment from a surgical oncological point of view. Let's welcome Dr. Amersi.
Thank you very much. Hang on one second, I just wanted to figure this out. Perfect. So I do want to let you know I have modified my talk so that it's not as graphic, especially since I'm following lunch at this point. All right, so what I'm going to do is I'm a surgical oncologist here at Cedars. My specialty is with small bowel, gastric, and rectal carcinoids. I work very closely with a multidisciplinary group, in particular Dr. Nissen, in doing a lot of our surgeries together and making decisions of which patients are appropriate for tumor debulking versus medical treatment. So as Dr. Pham had presented earlier on, we know that the incidence of NETs are rising steadily over the last several decades. And although the overall incidence is low compared to other GI malignancies, the prevalence is common as patients are now living longer with the disease for a longer period of time, unlike other GI cancers. GI NETs are the second most common malignancy after colorectal cancer, and a majority of these arise in the GI tract. The most common is the small bowel, and within the small bowel, a majority of these are in the ileum, which is the distal part of the small bowel. No talk from a surgeon is complete without anatomy, so I do want to go through a little bit of anatomy with you to make you understand. Liver, this is the gallbladder. When we talk about removing gallbladders at the time of your surgery, this is the pancreas. Stomach, this is the first part of the small intestine, the duodenum. This is the small bowel. The small bowel is freely floating in your abdomen, unlike the colon, which extends down here to your anus, is fixed to the side wall. So the small bowel, if you were to make an opening into the abdomen, you could actually, what we call, eviscerate the entire small bowel through a hole and be able to put it right back in. The colon, you can't do that. You have to release all the attachments along the side wall to be able to do that. So what has contributed to the improved survival that we've seen over the last decade? Obviously, patient education, doing conferences such as this, the websites, high-dose octreotide, lanreotide, PRRT, improved monitoring with biomarkers, and obviously aggressive surgical approach to these patients. And really, it's the development of multidisciplinary centers with expertise in neuroendocrine tumors that has really changed a lot of how we approach these patients. So surgery remains the only potential curative therapy when a tumor is localized. Really, when patients present initially, the first thing when we meet for our neuroendocrine tumor boards, we really look at first, is surgery an option for these patients before we look at anything else, because that's really the best chance for curing patients. For patients with regional I mean nodal disease or metastatic disease, cytoreductive surgery with tumor debulking has been associated with improved survival. So if you can get all the disease out, you offer the patients the best chance at survival. In terms of small bowel NETs, metastatic potential is not predicted by the size of the tumor. So tumors less than a centimeter, so tumors that are 2 millimeters, 5 millimeters, have about a 15% chance of having metastatic disease at presentation. 50 to 60% of tumors that are 1 to 2 centimeters in size, which are small, are metastatic at the time patients present. 30 to 50% of our patients present with a primary tumor not localized. So they undergo a CT scan or an abdominal ultrasound, and then there's liver disease found, and now they're referred to us for trying to find where the primary is, whether it's a pancreatic, small bowel, rectal, and it's really our job to try to figure out where the primary is first to make decisions about treatment. More than 60% of our patients have metastatic disease at the time of diagnosis with small bowel cancers. Now, in terms of prognosis, it is challenging because, as Dr. Pham had pointed out earlier, it really depends where your primary tumor is, whether it's localized, regional, that's with nodal disease, or distant disease. And our discussions, like she said, are really directed in terms of where the tumor is and the extent of disease. So, at Cedars recently, we've begun to look at whether the primary tumor site staging can possibly predict clinical outcomes. Specifically, we were looking at small bowel carcinoids and looking at location. So is a duodenal carcinoid different than an ileal carcinoid or a jejunal carcinoid? So our whole purpose of this study was to look at the significance of the location of the primary and if there were any factors in these patients that could be contributing to why it is that someone lived longer depending on where the location was, given it's all in the small intestine. So we looked at a SEER registry, which has histologic confirmation of patients between 1988 to 2009, and we looked at overall and disease-specific survival based on the primary location within the small bowel. There were over 3,700 patients in this database with small bowel primaries. A majority of them were ileal primaries. Like I said earlier, a majority of small bowel neuroendocrine tumors are in the ileum. And if you look at it, most of the duodenal primaries underwent local excision. So this, when we say local excision, that's usually endoscopic excision. Whereas the other small bowels, jejunum, ileum, most of these patients underwent some form of a resection. And when we say debulking, that usually means a resection of nodal disease at that time or potentially liver resection being done at the same time. We looked at the number of lymph nodes examined. Surprisingly, if you look at this, so SEER registry is all the hospitals. It's not just cancer centers specifically, so these are all community hospitals where data is collected. You'll see that up to 40% of patients who underwent small bowel resections did not even have lymph nodes taken out at the time of their surgery. For duodenal, most of us could understand because most of these patients are treated with endoscopic resection, so they're not undergoing surgery. It's just done when an EGD is performed, so you're just resecting the lesion, and obviously no nodes would be taken out for those procedures. When we looked at their survival, patients with duodenal carcinoids did the best compared to ileal and jejunal carcinoids. When we looked at disease-specific survival, so these are patients who, if they survived in terms of their recurrent disease as opposed to dying of something else, patients with duodenal carcinoids also did much better than whether the primary was in the jejunum or the ileum. When we looked at all the factors, so this is looking at lymph nodes, the gender of the patient, the race of the patient, where the primary tumor was located, primary tumor sites did not end up being a significant predictor of outcome in the end. So although duodenal carcinoids did end up being superior, in general, when you looked at all the factors, we could not use that as an independent predictor of survival. But there were two things that did stand out: the number of lymph nodes taken out and the number of primary tumors in these patients. So we took this a lot further and looked at whether nodal dissection makes a difference. If you looked at that slide I showed you earlier on, 40% of patients who underwent small bowel resection, so these are open operations, did not have any lymph nodes taken out at the time of their surgery. So we looked at the extent of lymph node and whether removing more lymph nodes would improve survival, and we categorized these patients into whether no lymph nodes, 1 to 6 lymph nodes, 7 to 11, and 12 lymph nodes, and whether this actually changed a patient's outcome. We looked at over 2,796 patients, and when you looked at patients with duodenal primaries, it really didn't make a difference if lymph nodes were taken out for these patients because most of these were localized early cancers. When you looked at jejunal and ileal, patients with jejunal and ileal primaries, it did make a difference. So there was a statistically significant difference in outcome if you had lymph nodes taken out at your initial operation. When you look at the number of lymph nodes examined, the more lymph nodes that are taken out, the better you do. So patients who had 12 or more lymph nodes taken out, the better you do. If you had more positive lymph nodes, obviously, the more lymph nodes that are taken out, the better they do, because you're obviously, if you're doing a small bowel resection, doing a limited resection, taking out only 1 to 6 lymph nodes or small number of lymph nodes, you're leaving disease potentially behind. So the more lymph nodes that were taken out in these patients, the better they did. So in conclusion from that study, we realized that the extent of lymph node assessment is really critical for adequate staging in these patients. And there really isn't criteria for surgeons in terms of removing lymph nodes when it comes to these operations for patients with carcinoid. And we really felt that there should be some definitive mandate. There is for gastric cancer, there is for colorectal cancer for all surgeons in terms of what is considered an adequate surgery in terms of lymph node removal. There is not for carcinoid. We looked at the other factor that I presented earlier was multifocality. So patients with small bowel carcinoids, if you have more than one tumor, does that mean your chances of survival are lower? We looked at the incidence of multifocality in primary small bowel tumors. We looked at the utility of double balloon, and I'll show you what that is, and studied the relationship between multifocality and, in terms of survival and recurrence. So we looked at our patient database. We had identified 104 patients that underwent surgery at Cedars between 2006 and 2013 and collected all the data that included surgical intervention and then outcomes. This is what a double balloon enteroscopy is. A retrograde double balloon is similar to colonoscopy in the sense that you enter through the anus, through the colon, and then you enter into the small bowel. And that's a retrograde. An antegrade is done through the stomach, and you enter into the small bowel. The way the gastroenterologist knows that the entire small bowel has been interrogated is when they do this procedure, they tattoo the area that they stop, and then this way, when you're going antegrade, you know exactly where you got to, and you'll make sure, you would know for sure that the entire small bowel had been interrogated for any additional lesions. So just in terms of a double balloon, it's great for looking in small bowel patients for multifocal disease. You can biopsy these patients, and these lesions are marked, especially for surgeons who are doing these procedures. We're doing these laparoscopically. These lesions are tattooed for us so that this way we'll be able to identify it, and I'll show you some pictures of what that looks like. And these suspicious lesions, which there was an additional lesion found here, or you can have a bulge, are biopsied, so this way we have confirmation prior to proceeding with surgery whether a patient has more than one carcinoid. So when we looked at our patients, 43% of them had a DBE completed, and 62% had additional lesions found. So this was patients who had one known primary, they had a DBE, and 62% of them had additional lesions found on a double balloon. Obviously, most of them were in the ileum. The ileum tends to have, is the most common site, but the ileum, lesions in so primary lesions in the ileum tended to have the most incidence of multifocality compared to duodenal or jejunal. When we looked at survival, though, having multifocal disease did not render a worse survival. So the patients lived as long as whether they had had one lesion. In terms of recurrence, it was the same thing. There was no significant difference in survival if you had one primary versus having multiple primaries identified at the time of your surgery. So once again, this study confirmed there is a high incidence. So the study demonstrates there's about a 30 to 40% incidence of multifocality in patients with small bowel neuroendocrine tumors. DBE is a valuable tool. But what's important is that multifocality did not have any impact on patient outcomes in terms of survival or recurrence. So the question everyone asks when they come in and they're initially diagnosed, should I be having a laparoscopic surgery? Everyone wants a laparoscopy. It's smaller incisions. Cosmetically, it's great. You have a shorter length of stay. For surgeons, there's decreased morbidity with doing an operation that is laparoscopic. The safety of the procedure has been well established in other cancers as well. And really, when it comes to deciding between laparoscopic versus an open surgery, the decision how we decide to do it is really whether the disease is localized, if there's nodal disease, if we're doing a combined procedure, and then more importantly, is this an oncologically safe operation just to prevent having a bigger incision? So just to give you an idea, laparoscopic surgery is, we have at least 4 trocars placed in, and this is the incision where the camera is placed, and this is the incision where we usually take out the specimen. So to take out a specimen, you need at least a 1-inch incision to remove it. When it comes to an open surgery, this is what an open operation would look like. So obviously a bigger incision, more pain, recovery is much longer, return to work is later. So when we do these, I've tried, if this is unfortunately graphic, you can look the other way. I've eliminated all the videos. Laparoscopic surgery, so we run the small bowel. We're looking for small lesions. This is the tattoo that the gastroenterologist will this is the tattoo marking. Now what's important is when you do a double balloon, you're looking inside the lumen of the bowel. As surgeons, we need to make sure that there's no disease on the outside of the bowel. So yes, we can look at it and see that there's no additional lesions, but we need to make sure, because carcinoid tends to be small disease. You can have tumors that are 1 or 2 millimeters that you may not be able to see with your eyes. And what we do is at the end of the surgery, when we're removing the specimen, through that, we can eviscerate the entire small bowel. Like I said, the small bowel is free in your abdomen. We can completely eviscerate it, and with our fingers, we run the entire small bowel to make sure that there are no additional lesions. This was a patient that I operated on. Unfortunately, it doesn't project very well, but this was an additional lesion found not through a double balloon, but at the time of surgery. So there's an area here constricting the small bowel that we had not known going in. One thing that's been very new that we've been doing at Cedars-Sinai is looking at patients with multifocal gastric carcinoids. So these are patients who have type 1 gastric carcinoids where the stomach is lined with neuroendocrine cells that are hyperplastic. So each one of these hyperplastic areas can become a carcinoid. And really, if you look back at the literature in terms of what is being offered to these patients, for type 1 gastric carcinoid, patients have an option of observation and waiting to see if they do eventually develop more aggressive carcinoids or if they develop metastatic disease. Most patients don't like the idea of waiting to see what happens when they know they've got multiple lesions in their stomach. The second is Sandostatin LAR. The problem with this is we don't know how long to keep patients on, because this is your entire stomach that's lined with potential cells that can become cancer, and some are already early forms of carcinoid. The third option is to remove the entire stomach, because the entire stomach is lined with these cells. So if you're approaching this from a surgical standpoint to prevent, you need to remove the entire stomach. Morbid procedure, and most patients don't want to sign up for something like that. And just to give you an idea, when you remove the entire stomach, you're removing it right at the junction of the esophagus and the stomach, and then we bring the small bowel and connect it to the esophagus. That's what a total gastrectomy is in terms of preventing future disease. So what we have been doing at Cedars is doing something less. The stimulus for these cells to become cancer is a hormone called gastrin. Gastrin is produced in the distal portion of the stomach, and that's called the antrum. So if we remove the antrum, is there a possibility that we can actually prevent these cells from becoming cancerous? We started doing these surgeries several years ago, and what we do is we resect just the distal portion of the stomach, and we connect small bowel to that distal portion. It is all done laparoscopically. We did 16 patients over the last several years. Most of these patients had tumors within the stomach. Some had it in the earlier part of the small intestine as well. And when you look at these patients, a majority had already 2 to 8 gastric carcinoids. So these were not just hyperplastic cells, but they actually had gastric carcinoids in their stomach that were not resected. So we're just moving the distal part. The carcinoids are actually left in place. The size of the lesions varied between 0.2 and 2 millimeters, and the way we know where these lesions are, they undergo gastric mapping prior to the surgery, and the entire stomach is biopsied, and the lesions are measured in size, so we know exactly how big these lesions are. And just to keep in mind, once again, we are not resecting these lesions. All we're doing is removing the stimulus for these cells to become cancerous. When we looked at these patients post-op, their gastrin levels go down immediately. So within 3 weeks, their gastrin levels are normal. When you look at their chromogranin level, this is pre-op. Within 2 weeks, their chromogranin levels are almost back to normal. When although it's only 16 patients, I'll give you an idea, this is the largest series in the United States. It's minimally invasive surgery. And for all our patients that we have done this procedure on, they've been as far out as 5 years. The shortest has been 6 months. And these patients are scoped at 6 months and then every year thereafter. And most of our patients within 6 months had a complete regression of the endocrine cell hyperplasia and formation of type 1 gastric carcinoids. So their type 1 gastric carcinoids actually resolve when we scope them again. We obviously don't have long-term follow-up on these patients, but we have patients as far out as 5 years now who've undergone these procedures who have not developed any additional lesions or developed metastatic disease from this procedure. So in summary, surgery still remains the only potential curative therapy for patients with localized disease from NET. Resection of lymph nodes is required. Prophylactic cholecystectomy, in terms of how we decide, it's really a decision based when we have our multidisciplinary meetings on whether we think these patients will need sandostatin postoperatively, and if they do, that's when we make a decision about doing prophylactic cholecystectomies. What's important to keep in mind, if you have one small bowel primary, there's a 30 to 40% chance of having additional lesions. And in terms of how we decide, each of our patients are presented at a multidisciplinary group meeting. Dr. Nissen is there, and then we make decisions of whether to do concurrent wedge resections or lobe resections at the time of the surgery for the primary lesion. And finally, I do want to emphasize once again, like most of our speakers have, being treated at a center where you have experts that specialize in this, that go through your imaging, that go through your pathology, that decide whether you need additional procedures to rule out multifocality. We make decisions on whether something should be done laparoscopic, open, whether we should be doing debulking at the same time, whether we should be addressing the liver disease at the time of the initial diagnosis, or whether we're going to do targeted treatment later by Dr. Friedman. And for patients also of refractory disease, whether they should be on clinical trials or PRRT. That's it. Thank you.